Single port transvesical simple prostatectomy for big median lobe. Today we present our updated technique and discuss our perioperative and postoperative outcomes of our initial series. Our case is a 64-year-old male presenting for acute urinary retention and severe LUTS. His IPSS score was 30 and quality of life was 6. His preoperative PSA was 4. He had a past surgical history of open inguinal hernia repair with mesh. On CT scan, he had a 250 cc prostate with a protruding median lobe into the bladder. The patient is positioned in a supine position with the operative table kept flat and no need for a Trendelenburg position. After draping, a 20 French Foley catheter is inserted into the bladder and a 3 to 3.5 cm suprapubic midline incision is made 2 finger breadth above the pubic symphysis. After dissecting the rectus fascia, the bladder is filled with 200 to 250 cc of saline and a 21 gauge needle guide is used to bladder aspirate for proper bladder identification. Then, 4 stay sutures are placed on the bladder using zero Vicryl and a 2 cm vertical cystotomy is made. Recently, Intuitive Surgical introduced a new built-in floating dock Da Vinci access port that we currently use. The inner ring of the wind retractor is placed into the bladder and the rolling ring is rolled over the sleeve to reach the skin. The balloon access port is inserted and the 25 mm dedicated single port multi-channel cannula is connected. An 8 mm assistant port is connected to the chamber seal and the bladder is insufflated to a pressure of 12 mm mercury. Here you can see the setup before robot docking, and for suction we use the remotely operated suction irrigation system or ROSI. After docking, the camera is placed at 12 o'clock, the Maryland bipolar forceps at 6 o'clock, the monopolar scissors in the right hand, the Cadier forceps in the left hand, and all instruments are inserted under vision directly into the bladder. The next key step is to identify the bladder trigon and ureteral orifices. In the case of a big median lobe like here, the medial lobe may require traction to expose the ureteral orifices, as you can see here. After identification of the trigon and ureteral orifices, the bladder mucosa is incised in a semi-lunar fashion. Enucleation of the big median lobe first facilitates further evaluation of the lateral lobes. To avoid out-of-plane dissection, the prostatic capsule is used as a landmark during enucleation of the prostatic adenoma. After excising the median lobe, the dissection proceeds to resect the lateral lobes until we reach the capsule, and then distally towards the apex proximally to the verumontanum. If the prostate gland is big enough, we do not make a special effort to remove the specimen in a single piece. Prostatic adenoma specimens are excised separately and placed in the balloon access port. The new Da Vinci access port offers enough space to place prostatic fragments without limiting the working space, and hence eliminating the need to undock the robot. After the enucleation and proper homeostasis, the bladder insufflation is decreased to 5 to 8 mm mercury for further decrease of the flap tension and size of the bladder neck. Next, we use a 3O V-lock monofilament barb suture to perform the posterior reconstruction. This step reduces the tension on the vesicourethral mucosal flap. Using the same V-lock suture, the anastomosis is completed in a running fashion anteriorly, towards the 12 o'clock on both sides. After completing the vesicourethral mucosa advancement flap and the closure, we make sure that the knot is short enough to prevent postoperative pain and future irritative symptoms. At the end, the anastomosis is checked for water tightness using a new two-way 20 French Foley catheter. And the bladder is closed in 2 layers with polysorb 2 ovicular sutures. Here you can see the incision immediately post-op and at 6 weeks follow-up. Total operative time was 113 minutes. The estimated blood loss was 150 cc's. The patient was discharged 2 hours 43 minutes after the procedure, and the Foley catheter removed at post-op day 2 with immediate continence, and we had no intra-op or post-op complications. For our initial 42 cases, the median inpatient hospital stay was 19 hours. However, for the last 20 patients, we have been discharging patients the same days after the surgery. Median Foley catheter stay was 7 days. Similarly, we have been successfully removing Foley catheter 3 days post-op. Post-operative IPSS score was 2.5 with 0 CCPVR and excellent post-operative maximum flow rate. None of the patients required continuous bladder irrigation with minimal opioids after discharge and minimal complication rate. So as a conclusion, the single-port transvesical simple prostatectomy allows for small single incision, no need for Trendelenburg position, same-day discharge, minimal opioids analgesia, and a 200% functional outcomes improvement. Thank you.